Chapter 20, Postoperative Care. The postoperative period begins immediately after surgery. The patient's recovery is first handled in the Post-Anesthesia Care Unit, or PACU. The goals of PACU are to maintain patient safety during recovery from anesthesia and to identify actual and potential patient problems that may occur because of anesthesia or the surgery and intervene appropriately. If a patient assigned to Phase 1 care on admission to the PACU is stable and recovering well, the patient may rapidly progress through Phase 1 to either Phase 2 care or an inpatient unit. An accelerated system of care called fast tracking involves admitting ambulatory surgery patients directly to Phase 2 care. Post-anesthesia care is divided into three phases: Phase 1, Phase 2, and extended observation. In Phase 1, the initial recovery period, this is where a handoff report occurs, which is standardized and interactive between the anesthesia care provider and the nurse. Basic life-sustaining needs are of the highest priority, and the patient is most prone to complications in this stage and require vigilant observation. During Phase 1, a complete physical assessment is performed with emphasis on the surgical area. Thinking about the type of equipment required helps to consider the intense monitoring and frequent care that the patient in Phase 1 needs. To manage the patient that has received anesthesia, various equipment is required. Everything from ventilators, various means of oxygen delivery, pulse oximetry, airways, suction equipment, means to measure blood pressure and vital signs, ECGs, even up to pulmonary artery catheters. MH, a 64-year-old white female, had subtotal gastrectomy for a mass found in the stomach. She's taken to PACU immediately following surgery. She is extubated and begins to awaken from surgery. She's thinking about what equipment is this patient going to require in their care. Everything from oxygen and ECGs, suction, blood pressure, pulse ox, IV fluids, and warming devices. Don't forget about hypothermia, as the surgery room is quite cold and this patient's been under anesthesia, completely unable to maintain their body temperature. The anesthesia care provider provides report to MH to you, the receiving RN. What patient information should be reported to you by the anesthesia care provider? That information, starting with the basics, should include patient name, age, the surgeon, and the surgical procedure. It should also have a thorough patient history, including the indications for surgery, their medical history, current medications, and allergies. That admission report should also include information about the intraoperative period, including the anesthetic used, other medications received, the amount of blood loss, fluid replacement required, and the patient's current urine output. Other things like unexpected anesthetic events or reactions, unexpected surgical events, vital signs, trends, laboratory results, or any other adverse occurrence. The ACP provides a complete report on MH. She received general anesthesia, an ET tube that has been removed, and an IV in the left arm infusing D5.2 normal saline at 100 milliliters an hour, as well as a urinary catheter draining clear pale yellow urine. The NG tube is draining pale green fluid. Her vital signs are stable. The abdominal dressing is clean and dry, and she is drowsy but arousable. What other postoperative assessments should you perform on MH on arrival to the PACU? Now consider this is the time period when most complications to anesthesia occur. It's important to continuously assess return of motor function and protective reflexes. Pain management may also be a major concern, as the return and repair of motor function also brings back sensation. Your highest priority always is going to be ABCs, airway, breathing, circulation. Is that airway patent? Does she require an artificial airway? Is the breathing regular? Are the breath sounds clear? Does she require any supplemental oxygen? How is her pulse ox and capnography? And for circulation, this is going to be a telemetry floor. We're going to have ECG monitoring along with vital signs, peripheral pulses, cap refill, and the skin color and temperature. For a neurological assessment, we should carefully monitor both the level of consciousness as well as their Glasgow Coma Scale. Their orientation, sensory and motor status, pupil size, are they equal, round, reactive to light? We all remember our acronym PEARL. And genitourinary, their intake, their output, and estimated blood loss. GI, we want to closely monitor bowel sounds and be aware of their return. Also, in G-tube placement, verify the suction is clamped, assess for any nausea, assess the initial surgical site dressing, pain, and other laboratory and diagnostic findings. Your priority nursing actions for MH should focus on preventing postoperative complications. What postoperative complications is an MH at risk for following a subtotal gastrectomy? Think about the wound itself, any dehiscence, meaning that surgical wound opened up, or evisceration, where we had a dehiscence, but we now have organs protruding through. Other things like infection, urinary retention, delayed gastric emptying, fever, hypothermia, pain. There's a lot of considerations and things we should need to be aware of in assessing for post-surgery. MH received general anesthesia, which is typically inhaled. She would have received narcotics for pain and neuromuscular blocking agents to keep her still in the OR table. She's 64 years old, and although there is no roadmap for when age-related physiologic changes occur, those changes should be considered. Airway obstruction is often caused by the patient's tongue blocking their airway, and is most pronounced when supine and extremely sleepy. Hypoxemia is a partial pressure of arterial oxygen, PaO2 less than 60, and is characterized by signs and symptoms of agitation and somnolence. Hypertension to hypotension, and tachycardia to bradycardia, and low O2 saturation, less than 92%. Atelectasis may be the result of bronchial obstruction caused by retained secretions, decreased respiratory excursion, or general anesthesia itself. Pulmonary edema, on the other hand, is caused by an accumulation of fluid within the alveoli, and may be the result of fluid overload, heart failure, prolonged airway obstruction, sepsis, or aspiration. In the postoperative period, patients are at risk for aspiration of gastric contents into the lungs. This is a potentially serious emergency. Bronchospasms caused by increased bronchial smooth muscle tone, resulting in closure of small airways, resulting in wheezing, dyspnea, use of accessory muscles, hypoxemia, and tachycardia. And hypoventilations, a decreased respiratory rate or effort, and increased arterial carbon dioxide levels. This may occur as a result of depression of the central respiratory drive, secondary to anesthesia, or the use of opioids. Here we have a diagram showing the causes and relief of airway obstruction from the patient's tongue. Atelectasis is another major concern. In figure A there on the left, we have a normal bronchiole and alveoli. When compared to figure B on the right, we have that mucus plug obstructing it. And finally, in the middle there with figure C, we have that collapsed alveoli resulting from atelectasis after absorption of air. Case study nursing interventions. What interventions can you perform to prevent respiratory complications? One is going to be proper patient positioning. In this case, we want lateral recovery position, once conscious supine position. If the patient has an airway obstruction, you may need to reposition the head or perform suctioning. Place the patient in the lateral recovery position until conscious. This position keeps the airway open and reduces the risk of aspiration if vomiting occurs. And then you can reposition them supine with the head of the bed elevated once conscious to maximize expansion of the thorax. Also consider things like oxygen therapy, coughing, and deep breathing to open up those lungs, along with incentive spirometer. We also want to encourage early mobilization and change the patient position every 1 to 2 hours. Pain management to support the depth of the breath that the patient can take. Again, deeper breaths work to prevent atelectasis and expand those lungs. Ensure that the patient is adequately hydrated. This will also help to thin those thick secretions. And chest physiotherapy, should we need to mobilize any of those secretions. Depending on the patient position, they may have pain if they've tried to cough. Even though that deep breathing and coughing is necessary to open the lungs, one strategy we can do is splinting with a pillow to help support the incision while they do their breathing exercises. For cardiovascular postoperative complications, consider things like hypotension, hypertension, dysrhythmias, venous thromboembolisms, or syncope. Patients most at risk for altered cardiovascular function include those with altered respiratory function, those with a history of cardiovascular disease, older adults, the debilitated, and the critically ill. Other considerations, including fluid and electrolyte, would be fluid overload if we've given them too much fluid, or do we have a kidney issue where they're not excreting urine, a fluid deficit, fluid imbalances, acid-base imbalances. That fluid retention results from the stress response and secretion of antidiuretic hormone and the activation of the renin-angiotensin-aldosterone system. Fluid overload may occur when IV fluids are infused too quickly, when chronic disease such as heart or kidney disease exists, or when the patient is an older adult. Fluid deficits, on the other hand, come from untreated preoperative dehydration, intraoperative blood losses, or slow or inadequate fluid replacement that can decrease cardiac output and tissue perfusion. Losses from vomiting, bleeding, wound drainage, or suctioning can also contribute to this deficit. Hypokalemia can result from urinary and gastrointestinal tract losses and can directly affect the heart contractility and may contribute to decreases in cardiac output and tissue perfusion. Patient history may also predispose the patient to fluid overload. Patients with renal failure or heart failure will be more susceptible to this volume overload, and patients who undergo GI surgery or receive diuretics may be likely to have electrolyte imbalances, may present as cardiac dysrhythmias or muscle cramps. Acid-base imbalances may also be seen in patients who have irregular breathing patterns or respiratory depression associated with anesthesia. What interventions can you perform to prevent cardiovascular and fluid electrolyte complications within this patient? Within phase 1, vital signs are monitored every 15 minutes and need to be compared with the preoperative and intraoperative to determine if signs are returning to baseline. Notify the provider if any of the following occurs, such as a systolic less than 90 or greater than 160, a pulse rate less than 60 or greater than 120, a pulse pressure difference between systolic and diastolic that narrows, the BP trends gradually decrease or increase over several consecutive readings, or a change in heart rhythm. ECG monitoring is recommended for patients with a history of heart disease and older adults who have undergone major surgery. Begin treatment of hypotension with O2 therapy to promote oxygenation of hypoperfused organs. IV fluid boluses will be given to normalize the BP. Assess surgical site to determine if excessive bleeding is the cause of the volume loss or hypotension. Treatment of hypertension centers on removing the cause of sympathetic nervous system stimulation and may include giving analgesics, assisting with voiding, and correcting respiratory problems. Rewarming corrects hypothermia-induced hypertension. The patient with pre-existing hypertension or has undergone heart or vascular surgery usually needs drug therapy to reduce blood pressure. Early ambulation is key, and while the patient may not want to get out of bed, the sooner we can get them up and moving, the better things will progress in their recovery. That early ambulation increases muscle tone, stimulates circulation, which prevents that venous stasis, and speeds up wound healing, and increases vital capacity and supports normal respiratory functioning. Those slow position changes may prevent syncope. Monitor for orthostatic blood pressure with any increase in mobility, slow changes in the body's position, monitor for emergence delirium, delayed emergence, postoperative cognitive dysfunction, anxiety, or especially alcohol withdrawal delirium, which may take several days to appear. What interventions can you perform to prevent neuropsychologic complications in this patient? The most common cause of agitation in the PACU is hypoxemia. Once you've rolled out hypoxemia or other known causes of postoperative delirium, sedation may be beneficial in controlling the agitation. Interventions to prevent perioperative delirium, other than reducing the depth of anesthesia, have not significantly reduced the incidence of emergence delirium. Until the patient is awake and able to communicate effectively, you're responsible for the patient. This includes monitoring physiologic status, having the side rails up and the call bell available, securing equipment, using 2 unique patient identifiers before giving drugs or completing treatments, and verifying allergies. Maintain normal physiologic functioning by achieving fluid and electrolyte balance, adequate nutrition and sleep, pain management, proper bowel and bladder function, and early mobilization. To help orient the patient, use specific aids such as clocks, calendars, and photos. Also, recognizing alcohol withdrawal delirium can be a challenge. Record and report any unusual or disturbed behavior so that a diagnosis can be made and treatment started, which can be very concerning. There are a lot more people dependent on alcohol out within society than you realize. Maybe people aren't even aware how reliant they are on alcohol. And unfortunately, those withdrawal symptoms can take several days to appear. What interventions can you perform to prevent pain and discomfort complications in this patient? A plan for pain control that includes behavioral modalities and control of anxiety is developed preoperatively. Patients are also taught to report pain and how it will be managed postoperatively. Single modalities such as opioid drugs, patient-controlled analgesia, PCA pumps, regional analgesics, local anesthetic infiltration that may be used postoperatively as well. They could also consider multimodal analgesia or the use of two or more analgesics with different mechanisms of action, such as opioids and NSAIDs combined together. A patient-controlled analgesia PCA involves that self-administered of a predetermined dose of analgesia via IV, epidural, oral, or transdermal route. Epidural analgesia is the infusion of those opioid analgesics through a catheter placed into the epidural space surrounding the spinal cord. The goal of epidural anesthesia is the delivery of drugs directly to opioid receptors in the spinal cord. Administration methods include intermittent bolus dosing, continuous infusion, and epidural PCA. The perineural local anesthesia, the infiltration of a non-opioid medication into the surgical site, is another way to manage postoperative pain. A disposable or mechanical infusion pump delivers the local anesthetic via catheter directly to the surgical incision site. Perioperative hypothermia is a core body temperature of less than 96.8 degrees Fahrenheit and occurs with heat loss that exceeds heat production. Contributing factors are skin exposure, use of cold irrigants, skin preparations, and unwarmed inhaled gases. Complications associated with this hypothermia can include vasoconstriction with resulting hypertension, compromised immune function, bleeding, untoward cardiac events, altered drug metabolism, increased pain, and shivering. This shivering can increase resting energy expenditure and oxygen consumption by up to 500%, which can lead to hypoxemia and MI's angina. Shivering can also increase carbon dioxide production, contribute to increased heart rate, blood pressure, and intracranial pressure, as well as significantly affect the patient's comfort level. Fever is often related to infection and may occur at any time after surgery. Urinary tract and respiratory infections, as well as the IV site itself, are other common areas for infection. Finally, malignant hyperthermia is a muscle metabolism disorder that's triggered by general anesthetic agents. It's characterized by a rapid rise in core body temperature and severe muscle rigidity. Other signs of this include tachycardia, hypercarbia, metabolic and respiratory acidosis, and elevated creatinine kinase levels. MH is a life-threatening complication that most often occurs during general anesthesia, but also may be seen in the 1-hour period immediately following the surgery. In order to prevent hypothermia, passive warming should be considered, and this would include measures to use of warm cotton blankets, socks, reflective blankets, and limiting skin exposure. Active warming involves the application of external warming devices, such as forced air warmers, radiant warmers, and heated humidified oxygen and warmed IV fluids. Applying O2 therapy via nasal cannula or mask to treat the increased demand for O2 caused by shivering, when shivering can be treated with opioids. Treated for malignant hypothermia includes the administration of Dantoline, and these measures to cool the patient, such as ice packs and cold IV solutions, and correcting acid-base balances. Use meticulous asepsis with wound and IV site care, and encourage airway clearance with deep breathing, coughing, and the use of incentive spirometer. Risk factors for postoperative nausea and vomiting include a younger age, less than 50 years, female, history of motion sickness, non-smoking status, an action of anesthetic or opioids, and duration and type of surgery. Delayed gastric emptying and slowed peristalsis can also result in this postoperative nausea and vomiting. Constipation may be another thing to consider on the opposite end of the spectrum, and may occur after surgery due to the anesthetic slowing the peristalsis within the GI tract. What interventions can you perform to prevent GI complications in this patient? Assess for the presence of postoperative nausea and vomiting. When ordered NPO, give IV fluids to maintain that fluid and electrolyte balance, and begin oral fluids as ordered and tolerated. When starting oral intake, offer clear liquids first and continue the IV fluids, usually at a reduced rate. If the patient tolerates oral intake, the IV fluids are stopped. Be alert to prevent aspiration if the patient vomits while still sleepy from the anesthesia, and position the patient in the lateral recovery position and have suction equipment available. Consider prophylactic antiemetic drugs for patients at high risk of nausea and vomiting, and complementary measures such as guided imagery that may support the nauseated patient. Constipation may be prevented using bowel protocols that include the use of stool softeners and laxatives. Assess the patient regularly to detect the return of peristalsis and encourage the patient to expel gas. Gas pains tend to become pronounced on the second or third postoperative day. Ambulation and frequent positioning may provide relief. Positioning the patient on the right side permits gas to rise along the transverse colon and aids its release. Again, assess for that return of bowel function carefully. Low urine output may be expected in the first 24 hours because of increased aldosterone and ADH secretion resulting from the stress of the surgery. Acute urinary retention can occur related to the effects of anesthesia on the micturition reflex arc, ability to feel full, and the ability to initiate voiding. The types of surgery, such as lower abdominal and pelvic surgeries, will also affect the ability to void. What interventions can you perform to prevent urinary complications? We want to monitor the urine output closely and have a good working knowledge of the type of procedure and if renal ischemia and cardiovascular compromise could have occurred. Make sure to administer IV fluids as ordered and may be the result of fluid loss in the OR, GI losses. If the patient remains NPO, will require hydrational support. And monitor that output with a catheter if clinically indicated. If not, remove that catheter ASAP to prevent infections and the patient's ability to initiate voiding. You can aid voiding by normal positioning the patient, sitting for women and standing for men. Scan the bladder with a portable ultrasound to assess volume of urine in the bladder and avoid unnecessary catheterization. Surgical site infections are the most common healthcare-acquired infection and have been associated with prolonged hospitalizations, increased care costs, and poor patient outcomes. The majority of surgical site infections are preventable with using evidence-based strategies, prophylactic antibiotics, surgical site skin preparations, and maintaining perioperative normothermia. Wound infection may result from contamination of the wound from three major sources: exogenous flora from the environment, oral flora, or intestinal flora. An accumulation of fluid in a wound may create pressure, impair circulation and wound healing, and predispose the patient to infection. To allow for drainage, the surgeon may place a drain in the incision or make a stab wound next to the incision. What interventions can you use to prevent a wound infection in MH? We should assess the wound carefully for signs and symptoms of infection, including the type, color, amount, and odor of any drainage present. Note if there is an increase in drainage when moving the patient, which may indicate accumulation of drainage associated with an infection. Many surgeons prefer to change the first postoperative dressing. The general signs and symptoms of infection should be monitored for fever or warm red skin surrounding the incision. Wound dehiscence, again, that separation of the surgical wound, is another major danger we should be watching for, and may be preceded by a sudden discharge of brown, pink, or clear drainage. The modified Aldrete scoring system, or other form of post-anesthesia scoring system, may be used to determine the patient's readiness to transition from phase 1 to phase 2. It's a modification of the APGAR scoring system used with newborns, and it has since been modified to more critical evaluation of the patient's oxygenation status, hence the word modified. The modified Aldrete scoring system takes into consideration the patient's consciousness, activity level, respirations, oxygenation, and circulation status. A score of 9 or 10 indicates readiness for transfer. Some institutions may accept a score of 8. Here we have that modified Aldrete scoring system, including the discharge criteria of consciousness, fully awake, arousable to voice, unresponsive, their activity level, are they able to move voluntarily or on command, in 4 extremities, 2, or no extremities. Also respirations, such as able to take deep breaths and cough, or dyspnea and shallow breathing. The scale would also assess oxygen saturation and circulation via pulse ox and blood pressure. Upon meeting specific criteria, patients are transferred from phase 1 to phase 2 care. Again, this is an inpatient unit. The inpatient unit chosen should be appropriate for the patient's surgical procedure or condition to better meet postoperative needs. Before sending the patient to phase 2 care area, the patient should have a return to neurologic baseline, being aware of the situation, oriented, and able to follow commands. Also being hemodynamically stable with blood pressure and heart rate within baseline or close to the the baseline. Surgical site should have minimal drainage, and the pain should be managed with a continuous plan for further management. Nurse-to-nurse communication is essential when the patient is moving from phase 1 to phase 2. That SBAR is a standardized communication tool that may be used to provide a complete report. Phase 2 care, again, is an inpatient setting, though it is an intensive care area. And in this area, we're focused on preparing the care the patient would require in the home and begin planning for discharge or whatever rehab the patient may require. This equipment would take many forms, everything from oxygen delivery, bag valve mask, the means to measure vital signs, means to manage hypo or hyperthermia, an ECG monitor or code card, stock of supplies, and a bladder scanner meant to assess for urinary retention. Patients may need to be transferred to an extended observation area, such as a rehabilitation facility, or remain on an inpatient unit for rehab. The nursing care continues to focus on preparing the patient for discharge and improving their means of self-care. Ambulatory may also be referred to as same-day surgery. The patient leaving an ambulatory surgery setting must be hemodynamically stable, mobile, alert, and able to provide a degree of self-care when discharged to home. The discharge teaching should include the patient and caregiver in its planning and provide them with the information and support needed to make informed decisions about the ongoing care. Also consider things like access to a pharmacy, a phone in case of emergencies, and access to follow-up care. Also provide the patient with actions and side effects of any medications, any activities that are allowed or prohibited, and dietary restrictions and modifications they need to keep in mind. Discharge teaching is of the utmost importance. Patients and their caregivers are expected to continue self-care of incisions, tubes, and drainage systems at home. In collaboration with a case manager, patient care navigator, discharge planner, the nurse helps to facilitate a safe transfer for home. Consideration for access to a pharmacy and a phone, symptoms of that should be reported, where and when to return for that follow-up care, reasons to seek help after discharge, and answered for any other questions the patient may have. Common reasons to seek help after discharge include unrelieved pain, questions about medications, wound drainage and or bleeding, increased drainage from a drainage device, and a fever greater than 100 degrees Fahrenheit. The patient is 2 days into her postoperative recovery. She is alert and oriented to person, place, time, and situation. The vital signs are blood pressure 155/74, a heart rate of 87 and regular, a respiratory rate of 20, and an oral temperature of 101.6 degrees. Her SaO2 is 93% on room air, and crackles are heard upon auscultation in her bilateral lower lobes. It was also noted that her skin was warm and dry. Bowel sounds are absent in all 4 quadrants. Her abdomen is tender and slightly distended. An NG is connected to intermittent low wall suction and draining brownish-green drainage. A surgical wound margins are approximated, and no redness is noted at the surgical site. A clean dressing is covering the incision. Consider age-related changes that may predispose this patient to postoperative complications, such as a decreased ability to cough, decreased thoracic compliance, or decreased lung tissue. Other complications we should be aware of would be atelectasis, pneumonia, dehydration, a wound infection, or phlebitis in a urinary tract infection. What priority interventions can you implement to address these potential complications? Again, notify the surgeon of your assessment findings. This patient may need a chest x-ray to rule out pneumonia or a urine sample to rule out a urinary infection. Use that SBAR to communicate all concerns to the surgeon. We should have the patient turn, cough, deep breathe, and use the incentive spirometer frequently. We should also increase her mobility, giving pain medication prior to the use of the spirometer or increasing mobilization. And finally, increase those fluid intake to thin secretions. 5 days after surgery, MH is being discharged. MH and her husband are anxious that she's being discharged so soon after a serious surgery. What is your priority for this couple? During phase 3, these patients may be discharged home or to an extended observation unit. Consider things like their hemodynamic stability and their return to baseline blood pressure or heart rate. Make sure their pain is managed and the patient reports pain as tolerable. The surgical site dressing is without excessive drainage. Tubes and drains are draining the expected color and consistency, and the fluid and hydration the patient may be taking, PO, or if the MPO, receiving via the IV fluids. While assessed in all patients, for our gerontologic patients, we want to take a close assessment of their decreased respiratory function, any altered vascular functions, drug toxicities, mental status changes, and their pain control. A patient becomes restless and agitated in the post-anesthesia care unit as he begins to regain consciousness. The first action the nurse should take is to A. Turn the patient to a lateral position, B. Orient the patient and tell him surgery is over, C. Give the ordered postoperative pain medication, or D. Check the patient's oxygen saturation with pulse oximetry. And that answer is D. Check the patient's oxygen saturation with pulse oximetry. The most common cause of emergence delirium is hypoxia. The nurse should assess the patient's oxygenation status very closely. While in the PACU, the patient's blood pressure drops from an admission pressure of 126/82 to 106/78 with a pulse change of 70 to 94. The nurse administers oxygen and then A. Increases the rate of the IV fluids, B. Notifies the anesthesia care provider, C. Performs neurovascular checks on the lower extremities, and D. Uses a cardiac monitor to assess the patient's heart rhythms. And that answer is A. Increases the rate of the IV fluids. The nurse is preparing to discharge a patient from the ambulatory surgery center following an inguinal hernia repair. The nurse delays the release of the patient upon discovering that the patient A. had IV morphine 45 minutes ago, B. has an oxygen saturation of 92%, C. has not voided since before the surgery, or D. had one episode of vomiting 30 minutes ago. That answer is C. Has not voided since before the surgery. Patients must be able to void before discharge from an ambulatory surgery center. The procedure in this case makes voiding before surgery essential. And anyway, that's all I've got for these slides. I'll see you in the next chapter.